Okay, so I think orthopedics is going through almost like the MAGA in USA. I think it's become the MISA in orthopedics. We used to say infection used to get a few lectures right at the end, but I think we've made infection look sexy again, and I think the man responsible for making infection very sexy is my co-speaker. So we talk a lot about it, and well done for all the efforts that you've really done. So here's a small take, a lot of learning from all of you over the past few years. I put my thoughts into it, and I've tried to give it as much of scientific basis as I could. So slide change. Okay, fine. So here's an example of something that happens very often. You change the wound you change the wound dressing somewhere about the third, fourth day. You see a small little spotting. 2-3 days later, it seems to get bigger. You wait it out, and you think, well, the patient's doing well, not really feeling very ill, very unwell, and you keep monitoring it. Somewhere about the time of the discharge, and the patient still got this ooze, and you say, look, I think we need to add some antibiotics or something. Patient goes home, comes back. Oops, I'm so sorry. I don't know why it doesn't seem to flick in through. So a few days later, the patient's got a big ooze coming in there, and then you're saying, look, I don't think we have an option. We need to go ahead and debride it. And 4 weeks later, this patient is now waiting for the first stage. And the problem that happened was we missed the boat in there. So that's a fairly common sight, and I'm sure all of you have been in this practice for a long time. I've seen these kind of slides. You can see it in front of you. It's your own patient, and you're really afraid to go and tell the patient, look, I have a suspicion something is not right. So the incidence of post-op wound drainage is somewhere about 6.2%. In that category of patient, the rate of infection is somewhere about 1/6 of them will actually go ahead and develop a deep wound infection. The worry that we have in our mind is what to do, when to intervene. Obviously, clinical assessment plays a big role, and I think we're all familiar. When you get a wound like this, there isn't much to do but to go ahead with the idea, look, I think we have a problem and we need to sort it out. Some more questions that need to be answered in the cases which are not as subtle as that, and these are some of the questions that came to my mind, which I put in, and I'll try to go through them as quickly as I can. So how soon should the wound be dry? So most wounds should be dry within 2 days, and all wounds should be dry within 4 days. If it's not dry by that stage, you're looking at having a problem. What's a draining wound? So somewhere like a 2x2 kind of a spot on your dressing beyond about 72 hours actually classifies as a wound which is drainage. There are other definitions, especially the 48-hour one is the crucial one, is a time duration which has happened, but anything beyond 4 days which is oozing is definitely infected. So there are lots of sort of ways to approach this problem. And the thing that always hits in our mind is there are patient's factors which actually bias our mind against it. So we get a very obese patient, we get a very advanced stage, you've done something, the surgery went on wrong, long tourniquet time, somebody was previously on anticoagulants, somebody who's got a malnutrition, and the things that come into mind is, oh, maybe it's because of this, and that's absolutely right, because all these things are actually associated with prolonged wound oozing. But still, for all practical purposes, we need to be circumspect once you see that the wound is draining after about 4 odd minutes. But these things are something that you need to worry about in these kind of conditions. And as I said repeatedly, why worry? 1/6 of these guys are actually going to get a deep infection. So what's a bare minimum treatment for a wound? So we're hoping that, by day 7 that you've already actually stopped their anticoagulants, you've given it a compression, you use some cold packs, you would reduce your mobilization, you stop their anti-inflammatory medication, and you got the bloods and all as balanced out which you can. So this is the bare minimum when you start to see a patient who's got a wound ooze. So there is enough evidence that anticoagulants, which is a double-edged sword, which we all use, Dr. Yadav is not there, so which does make an actual difference in terms of how the patient actually behaves. So this stopping them is definitely one of the most easy and the most acceptable thing to do. So what is an acceptable kind of a classification? So this is the classification which was given by the International Consensus Group. What you're really looking at, somebody who's got moderate. Now that's when you need to start suspecting it, not when you get to an excessive or a massive kind of a thing. So remember that figure that we talked about, 2x2 kind of a dressing, which is an ooze which keeps on showing on the wound, is a problem. So should you use an extended antibiotic usage for these kind of things? And a complete consensus, it does not help at all. So in fact, it might even be counterproductive. So you might just be killing the low virulence organism, and the higher virulence one, the ones which are going to get actually cause a bigger problem. They are actually thriving because you kill the low virulence organisms. So in this situation, you can think about if you were already on antibiotics from before, your old antibiotic is anyway not working. So there's no point continuing. And if you actually have already stopped antibiotic, again, putting somebody on antibiotic doesn't really work. Does PICO really work in this kind of a situation? PICO normally is recommended actually only for the first few days. So you can't even actually expect to carry it beyond day 7. There is no doubt that PICO has its own advantages and all. And in fact, if you look at the high risk category which I put, there is some benefit to be given by adding PICO in those situations. PICO does seem to make wound heal earlier. It does have some sort of an effect. You can't really quantify it, but there's enough evidence to look at which says there is some beneficial effect in using the PICO. Does the nature of the discharge actually matter when you're looking at the discharge? So as it really happens, majority of the time you're going to see either a serous or a serosanguinous kind of a discharge. So you can't truly take a call on this. You will hardly ever see a purulent discharge. So the sanguinous one is the blood one, which often confuses you because you think, oh, that's just the accumulated blood coming there. But very soon it normally changes into that watery kind of a serosanguinous discharge. So that's when you start getting confused just looking at that kind of a oozing which has happened. In my opinion, don't get biased with that. So the blood test. So we know about all these blood tests. I think all of you would do it. The thing to understand is CRP is your clinic, is really the thing you need to look at. Your CRP should really peak within about 48 to 72 hours. If it's actually not, it's actually going beyond that kind of a thing, you most likely have a problem on your hands. So any CRP which is actually elevated beyond that 4 to 5 day stage is actually asking for an intervention, or at least making you suspicion that something is going to happen. So remember that kind of thing. 4 to 5 days after that, the peak should happen within the 2 to 3 days, and then you need to be looking at why is it not coming down. ESR not so helpful actually to look at it. Now people talk about variation in the CRP and say, well, there's a lot of variations based on the gender and everything. No doubt about that. There are there are very minimal gender variations which are there. More importantly, does the level of CRP correlate with the level of problem that you're having? And the answer to that is yes. Actually, the higher the level of CRP, the more likely you actually have a problem coming. So this is the sensitivity and the specificity of all the tests which are there. We all know that CRP is one which you would use. If you have all the three, CRP, ESR and white cell, all of them elevated, you really have a problem. So that's a deal done kind of a stuff. Now look at ProCal, which is something which we never really thought about. Useless as a sensitivity, specificity, positive predictive value. But if you look at the negative predictive value, which is to say, if your ProCal is actually below a certain kind of a level, 0.1 is the one, you're almost sure that you don't have a bacterial infection happening. So ProCal has a better negative predictive value. In terms of the other ones, they have a better positive predictive value. I've not added anything on synovial fluid. I'll come to that. Special test. So ultrasound, bone scans and all, in my opinion, totally use this. I don't think it helps you in that 7-day stage to make a decision at all. Special tests, we don't have access to a lot of them. Stop doing, I don't think IL-6 really is going to help you too much. Looking at the literature, we don't have alpha defensin. You can use a dipstick because it's so easy to do kind of a stuff and good to convince a patient, but otherwise maybe not so helpful. So trust the basic test which normally would do the trick. What about swabs? Useless, absolutely useless. There's no point actually doing a swab. Is aspiration of the joint is something to be done? The answer is overwhelmingly yes from my side. And the reason for that is you're actually having a gram staining done, which is the quickest thing that you have in your mind. You can actually provide a sample for the culture. You can actually understand what antibiotic am I going to mix in my cement if you want to go in. You can understand what you're going to use for your wash. And the other thing that has come out is the number of white cells count in that. So if you have your white cell count somewhere over about 11,000, you have a fairly high sensitivity on this. And that's something that has been proven in lots of publications. A high white cell count, especially if you get it beyond about 16, it's a clear winner. You have, well, it's a clear loser actually, that you have an infection kind of a stuff. The CRP levels, again, as I said, higher levels indicate a bigger problem. Kim actually spoke about it in his paper. So why do we keep harping on the 7-day kind of a thing? So we understand there's a small window in which you have to get in. The biofilm formation is happening within a few hours of the infection settling it down. So it's not, you have to beat it before it gets properly formed. Proper formation is about 3 weeks down the line. So one thing that has been noted is for every extra day of drainage, you're getting a 42% increased risk of wound infection and a 29% of that is a knee replacement and 29 a higher chance of getting a hip replacement in the hip replacement. So there's a huge number of papers which talk about what is the incidence if you have a persistent wound drainage. Approximately somewhere about 1/5 of them are going to get a deep infection. So the thing that has been shown in a lot of papers is the longer you wait, the lesser the chance you have of beating the infection to it. So earlier management actually works better. So that's why the 7-day window comes in. It's not too early, but it's also not too late. You can actually reduce your chance of deep infection. The papers showing between 7 and 10 days itself, you can actually reduce the kind of infection. That's a survey which was taken by the Netherlands people. Somewhere about 60% of the people are looking at that 7-day window and saying, I think I would go in if it's not done. So what to do with if you have an infection? The answer is, I think you pretty much know, all of you know, and we are all doing all that, changing the polyliner, giving it the lavage. What has been added more and more is betadine and peroxide. Picked it up from you, Javed. So the other thing that we are doing differently now, which we're not doing, is hydrocin. Hydrocin actually works against an MRSA and actually against Pseudomonas as well. So hydrocin is a fluid. The only problem with this fluid is you actually dip your wound into it, then you need to actually wait for 15 minutes in which you need to chat up the nurses and everything. So, but you need to leave it there for a while before it acts. So it's an osmotic kind of an agent which enters into the cell and actually blows up the cell because of the imbibition within the cell itself. So there are few reports coming. We've actually had limited success. We've been using it for a little while now, but I highly recommend if somebody's thinking of using it, hydrocin is something to add on to it if you got the wound open. So just picking up a bacteria itself is not enough. You actually need out of 5.
Can we conclude?
Okay, sure. So though you need to pick up a bacteria depending on it. So the duration of antibiotic, this has always been a subject of this thing. Is it the same to continue the antibiotic when you're doing a 2-stage kind of a thing, or can you actually cut it short at this time? The jury is really open on this, but it looks as if you still need your 6 weeks of antibiotic. In fact, why 6? People are now talking about going to 12 weeks of antibiotic to do this. So these are some of the criteria which are put forward. We're keenly looking at this study which is going to come up about what to do with kind of these leaky wounds. The take-home message is it's never really easy. You really need to go with the idea that, look, confront the patient, tell him it's a problem. If you do all that, you could actually dodge that bullet. Thank you so much.